Everybody, I think we'll go ahead and get started. I'd like to welcome you to today's Prevention Research Center for Healthy Neighborhoods seminar series. Today, the July installment of our series. It's the last one of this year. We, of course, take next month off and things will resume in September. Welcome. If you've not been here before, welcome to you. There is a sign-in sheet. We like to track who's attending and also be able to reach you for up-and-coming seminars and other activities that might be of interest. So please do sign in on one of the sign-in sheets. Today's speaker is Martha Sajatovic, and she is professor of psychiatry and neurology at Case Western Reserve University. She describes herself as a researcher, educator, and clinician who's devoted herself to the study and treatment of traditionally hard-to-treat populations with nervous system disorders. She's currently the director of Psychiatry at University Hospitals Medical Center and holds the Willard Brown Chair in Neurological Outcomes at University Hospitals Health Center and Case Western Reserve University School of Medicine. She is going to be talking with us today about a project that is in the third iteration. It's been a series of projects that have actually been funded by a subgroup of grants underneath the Prevention Research Center umbrella called Special Interest Projects. And there have been a series of projects and leading to the development of a really nice intervention that has taken off and has received quite a bit of recognition nationally. So we'll get to hear a little bit about that, and then my understanding is that there's going to be a panel discussion. We will then open it up to broader conversation and discussion for today. So Martha, welcome.
Okay. Thank you very much, Sue. I definitely appreciate the opportunity to come and speak to this group. I think this is maybe the third time, something like that, if I'm remembering correctly. And I'm delighted to come back. I remember this as being not only a warm and welcoming group, but a very enthusiastic group with a lot of great comments and questions. So I'm just setting you up that my expectations, you guys have made my expectations very high. So I hope that we'll get a bunch of really excellent comments and questions again. The format that I'm going to take today is we're going to take about an hour and 15 minutes, and I'm going to go through some overview slides that just give you a little bit of background about our program, what it looks like, kind of the different stages that we took. And then I would say the meat of our discussion is going to be our panel. So I have a posse that I travel with today. You're going to get a chance to meet the posse in just a few minutes. And I hopefully you will be both entertained and educated. So let's start off with talking about really what I sort of envision and our team envisions as science to service in targeted training in epilepsy self-management. Science being approaches and curriculums and interventions that we developed here at Case with funding from the CDC. And then a little different from what happens with some of the research projects that I have been involved in, where we do a project and we write a journal article and then we just sort of forget about it, and it gets put into volume 77, pages 1 through 16, 1992, right? You've all seen that. Instead, the idea is to take what we learn through our science and communicate it into service to our community, using stakeholders that we have in our community and using partners who can help us to get it done and bring our services to the community. My disclosure information, you have that in your slides. So let me just give you a little introduction. So the focus that we are addressing here is people who have epilepsy. Epilepsy is a neurological disorder. It's one of the most common neurological disorders all across the world. We do see it all across the world. What happens with epilepsy is people have recurrent and seemingly unprovoked seizures. I mean, there are some things that can sort of trigger seizures, but generally it's a condition that's kind of unpredictable. People don't know when they're going to have a seizure. And if you can imagine living with a chronic health condition is hard enough, but not knowing when it's going to sort of break out and cause a seizure is extremely stressful. People with epilepsy have higher risk of premature death, 3 times higher in epilepsy than the general population, so it's a potentially very dangerous condition. Rates of some of the more serious mental illnesses, such as schizophrenia, bipolar disorder, or even depression that recurs and may be quite severe, are much higher than in the general population in people with epilepsy. And we know, unfortunately, that epilepsy and mental health conditions are both heavily stigmatized conditions. They both affect the brain, and perhaps because we can't really see, the biological marker. Like if you have hypertension, you can check your blood pressure, and you can see stuff. But with seizures and with mental health conditions or psychiatric conditions, we know less about them. It's not obvious, and there's a lot of negative societal reaction or stigma toward that. Suicide rates, unfortunately, are 5 times higher than in the general population. So, a condition that's very challenging to live with, highly stigmatizing. What can we do about it? One way to approach it is through epilepsy self-management. Epilepsy self-management has been defined as the processes that are used to control seizures and manage the effects of epilepsy. Current approaches that we know are successful are derived from evidence-based models of chronic illness management. And self-management, I'm using the acronym SM here, are not just behaviors or health lifestyle changes that people put in place, but they actually have biological effects. So there's studies that show you can reduce stress hormones, so biological stress hormones, inflammation markers, and even the variability of heart rate with self-management. So these are very powerful care approaches. To give you an additional bit of background, our team here at CASE is part of the Managing Epilepsy Well Network, or MU network. There are 8 sites across the United States. The coordinating center is in Dartmouth, but you can see where the other sites are. The mission of the MU network is to advance the science related to epilepsy self-management, implementing research, conducting research in collaboration with network and community stakeholders. What are the things that get in the way of epilepsy self-management? So there's a bunch of barriers. Forgetting to take medications is one that's significant. There are anti-epileptic medications or drugs, AEDs, that can often either totally control seizures or at least partially control seizures. People might have a lack of understanding of their treatment goals. So the difference between prophylaxis versus symptomatic treatment. So epilepsy is one of those conditions where you have to use what we call prophylactic treatment. You have to take the medications. You have to often get them up to a certain blood level, and you have to stay and sustain that blood level in order to control the epilepsy. You can't just take it like you take Tylenol when you get a headache. But that's something that people have to wrap their heads around. Sometimes medications don't work as well as we'd like them to work. That's pretty common. Side effects are common. Depression or other psychiatric symptoms are very common. We talked a little bit about that. We talked about stigma, lack of social supports, and lack of access to care or medications. So maybe some of our panelists might touch on this a little bit later in our program, but in the state of Ohio, if somebody has seizures within the past year, they are not permitted to drive a motor vehicle. So if you can imagine, if you can't drive, how difficult that keeps you away from social contacts, makes it hard to find jobs, unless you're really able to access public transport. And we know how fantastic the public transport is. I know you guys get that. But, having epilepsy can impose certain restrictions. If seizures are not well controlled, their complications are more likely. So there's something called sudden unexplained death in epilepsy, 5 to 7% of deaths. So people usually will have uncontrolled seizures, and sometimes that's fatal. Suicide is unfortunately relatively common. People have, 30% of people get seizure-related injuries. So depending on the type of seizure they have, if they lose consciousness and fall, you can imagine wherever that fall might be, the complications could be severe. Some complications are preventable with self-management. For instance, adherence, which is associated with a threefold risk of mortality, could be something that could be a target. And poor adherence also increases the rates of fractures in emergency room or emergency department visits and rehospitalizations. So helping people to stay on track with their medications and make lifestyle changes could also potentially reduce complications. A little bit about mental health conditions in epilepsy. 20 to 70% people with epilepsy will have or meet criteria for a psychiatric condition at some point in their lives. I mentioned conditions like schizophrenia, bipolar disorder, depression are common, anxiety, PTSD, kind of the whole menu. And psychosis risk, sometimes related to the seizures themselves, are more common with a 6 to 12-fold general increase compared to the general population. So that's your background. Our situation that we were dealing with our team at CASE was, how can we address some of the most common psychiatric symptoms, and how can we improve outcomes? We were particularly interested in reducing depression. We wanted to know what works, what's practical, what could be sustained in typical practice or in community settings. Can we reduce depression and improve premature mortality by potentially avoiding some of those complications that I went over a couple of minutes ago? So the MU network has been particularly focusing on depression. There was a study using an approach called PEARLS that looked at long-term outcomes for people who had depression in epilepsy. And they did a randomized controlled 18-month trial where they compared usual care to their PEARLS intervention, which is a self-management program. One of their outcomes was depression based on a scale called the Hopkins Symptom Checklist 20, HSCL. And what you see here is that over the course of 18 months, the blue line shows the PEARL depression scores compared to the red line, which is treatment as usual. And you can see that significantly separated, suggesting that PEARLS was better than treatment as usual in improving depressive symptoms in people with epilepsy. Another project was called Uplift. Uplift stands for Using Practice and Learning to Increase Favorable Thoughts. That's where the Uplift acronym comes from. It's a mindfulness-based cognitive behavioral intervention to treat depression or depressive symptoms in people with epilepsy. The delivery is telephone and internet-based group. 8 sessions from noticing thoughts to preventing relapse. So the sessions will have a different menu of topics within it. Their research results suggested, using a randomized controlled trial design, that people in Uplift had a decrease in depressive symptoms based on a scale called the Beck Depression Inventory, and an increase in knowledge and skills more than the treatment as usual waitlist condition. So similar to what I showed you about Uplift, with PEARLS, Uplift was superior to treatment as usual. The other thing that was interesting is they showed that depressive coping self-efficacy, so a person's ability to kind of manage their own emotions and mood, was improved with Uplift. The group mean increased by 7 points compared to only 0.2 point in waitlist control. So not just the symptoms themselves, but also the person's ability to regulate and manage their own emotional state. So then several years ago, we got funding, a short little project. It was a 2-year program, and we developed and tested a program called Targeted Illness Management for Epilepsy and Mental Illness, or TIME. Dr. Samla, too, is a neurologist here at CASE, who was our co-investigator neurologist on the study. We had two phases of rolling out the study, and I'll kind of go through that quickly, because I think I might have presented some of this data in a previous PRC program. But basically, we had phase 1 that lasted about 10 months. We convened a community advisory board to help us adapt a self-management curriculum that we were using for other chronic health conditions. There were some folks from the PRC who participated. We also used the Community Network of Community Advisors, or NOCA, to help us develop the program. And then in phase 2, conducted over the next, which was a 3-year program, the next couple of years, we did a randomized controlled trial where we randomized 22 people to our time program and 22 to treatment as usual. Our primary outcome was depression, or depressive symptom severity. I'm actually going to skip the inclusion. So our phase 2 results, average age around 48.3, 59% women. And actually that's pretty good. Unfortunately, one of the challenges we have, and I'd love to hear your thoughts later when we do kind of Q&A, is that we have a hard time getting the men to come in to participate in self-management programs. The MU network as a whole runs about 2/3 women and 1/3 men for their enrollment. So we were at 59%. That isn't bad, but you know, I'd love to hear your suggestions about how we can get more men to enroll. 25% with a less than high school education, 70% unemployed or unable to work. And I put those 2 bullet points so that you can see, though, even though people had the education, they weren't able to translate that into occupational gain, often because of the epilepsy. Annual incomes were less than $25K. Mental health conditions, schizophrenia, bipolar disorder, depression, and the average number of seizures in the last month was between 5 and 6 seizures. So that's quite a lot of seizures, if you can imagine. Having an unexpected event like that, like once a week or more, that's pretty disruptive. All right, so our primary outcome was the Montgomery-Åsberg Depression Rating Scale. It's a rater-administered depression scale. One of my posse, Carrie Zimmerman, is like the queen of the MADRS. So if anybody has any questions about that rating scale, she can talk about that till the cows come home. But what we saw is that time, which is the dark blue line here, compared to treatment as usual, which is the red line, had a statistically and clinically significant separation over the course of 4 months. Most of these folks had had epilepsy for at least 2 decades. So pretty significant that we could see that kind of change in 4 months. So we were jazzed about the effects and the outcomes and wanted to take it further. So in collaboration with the Epilepsy Association, we have a representative here from the Epilepsy Association who will give you her 2 cents. But we partnered with the Epilepsy Association, and we went to the Cuyahoga County Drug Addiction and Mental Health Services Board, or ADAMS Board, and asked them for support to help us roll the program out to the community. They were, fortunately, in agreement with us and supported us. We rolled it out in the community. We cited it or conducted it at the Epilepsy Association offices. We had fairly broad entry criteria, more broad, certainly, than our little research study. Slightly shorter intervention. We went down from 12 sessions, I believe. It went down to 10. But what we found, interestingly, is even though we relaxed the entry criteria, we didn't have a full-on research efficacy study, our results in depression severity were in line with the original time study. So that was pretty cool, and that was what we were looking for. So, enthused by that, kind of encouraged by the findings so far. We also applied for another grant, another SIP, and this was what Dr. Flocky mentioned, is we're part of the Special Interest Project Network, which allows us through the PRC to apply for and ideally obtain funding to do kind of special interest or areas of expertise. Epilepsy only affects about 1% of the population, but if you have it, it like rules your whole life. So fortunately, the CDC does provide some support for these kinds of conditions. What we did was we adapted time so that it could be administered remotely using a web delivery or a phone delivery and engage high-risk people. So high-risk people with epilepsy who had what we call negative health events, or NHEs. NHEs are defined as a seizure, a ED or ER visit, emergency visit for whatever cause, a hospitalization, a self-harm attempt, or an accident. Okay, so I think most people in this room, probably all of you, would agree that those are things that you would not want to happen in your life. But that was our entry criteria. People had to have epilepsy and one of those NHEs within the last 6 months. So we would consider that kind of a high-risk group. Just like with time, SMART was developed, so it was refined with our community advisory input. Also helpful with the PRC NOCA, provided some input, some recommendations. And then we tested SMART in a randomized controlled design, comparing SMART to waitlist controls. So just to give you an idea of the curriculum, and time and SMART have a lot of similarities. Time was more intensive. It was, kind of the original version. Maybe what they use that cliche, the Cadillac version, although Cadillacs aren't so great anymore, I guess, so I need to find another comparison. But they have a lot of content similarities. So in SMART, we had step 1, that was a group format, in-person 60-minute session, up to 10 people in each group. The groups are co-delivered by a nurse educator and a peer educator dyad. Peer educator is a person with epilepsy who also has had, in our enrollment criteria, at least 3 lifetime NHEs. Okay, so they would know what they were talking about and walk the walk. They don't have to be the perfect person who understands everything and have mastered all their life challenges, right? You just have to walk the walk and be willing to share. That's a key. Following that in-person format, taught people how to use their computers. We provided some personal tablets. Then we had 7 group format sessions delivered in a web-based format. There were posters and graphics emphasizing interactive discussion. Telephone call-in was available for those who either can't or won't use the internet. Group sessions were done over the course of about 8 weeks, and we had a detailed curriculum with semi-scripted instructions. And one of our nurse educators is here today who can share any insights about that if you have specific questions. This is the curriculum. I'm not going to go over it in big detail, but every session it's kind of a menu thing. It'll say what we're covering, how long you take to cover that topic, and then, as I said, there's a little bit of script and some discussion points. Let me just give an example. So session 7, social supports and using your available supports. We know that stigma is a big deal in epilepsy. How do you swim upstream on that? Advocacy groups for epilepsy. So this is where we talk about resources in the community, like the Epilepsy Association or other resources in town. And then a personal care plan to take care of the mind and the body. So that epilepsy is a brain condition, but epilepsy causes problems in the whole body. So we don't just focus on seizures in the brain, we focus on the whole body. Okay, so looking at depressive symptoms and quality of life, we did a 6-month prospective design where we had 6 months of the intervention, 6 months of wait list, and then we looked at outcomes at the end of 24 weeks. And what we saw is that, fortunately for us, in our participants, SMART participants had a reduction in depressive symptoms as measured by the self-rated PHQ-9, the Night Patient Health Questionnaire, and the MADRS that I showed you before. And it was significantly and clinically significantly different. And also quality of life was improved in people who were in SMART compared to waitlist. So this was a successful randomized controlled trial. And I'm just throwing something up here, just as kind of I won't spend a lot of time on it, but one of the other things that our group at CASE has been doing is developing and leading an integrated database initiative across the MU network. So each of these 8 sites have been doing work now since 2009. So we've got a decade worth of research. And every site has their own little database that they did a study. So what we've been doing is encouraging everybody to share their data. And we're pooling it together here at CASE. And we're harmonizing and figuring out how we can crosswalk this data. And so we just recently completed an analysis. This is actually unpublished data for you guys to look at. So it's kind of hot off the presses. But in a sample of over 470 people with epilepsy, what we did is we combined everybody who was in an evidence-based self-management program, right? And we looked at controls, because they were all waitlist controls, or treatment as usual controls. That's the black line. And then the blue line is scores on the PHQ-9 in anybody who was in a Mu Network epilepsy self-management program. Combine them all together. Visit 3 was around 6 months. And what you can see is, starting off at a score of 9-ish, which is the threshold for moderate to severe depression, we see that people that were in the intervention, any of the Mu Network interventions, had significantly greater improvement in depressive symptom severity compared to those who were in treatment as usual. So it wasn't just a one-off, but we see this across the whole network in these interventions that are developed in this team-wise fashion. Okay, so just to kind of wrap things up, evidence-based epilepsy self-management approaches can reduce depression, epilepsy complications, and other health outcomes. Approaches that are practical and can be scaled up in the community should be embedded into current models of care. We can say a little bit about that if people have questions, but the Epilepsy Association and our team at CASE are currently in the process of implementing a community-based version of SMART. So we have IRB approval, and we're starting to enroll, and Karen Zimmerman is here. And she has our IRB-approved flyers, and if anybody has any suggestions or referrals or would like to participate if they have epilepsy themselves or have a friend or family member, we are open for business. Future directions, we'd like to increase the use of standardized assessment of depression in people with epilepsy. So I showed you those PHQ-9 scores. So, but you know, if you got to measure something before you can say that it's changed. Right? So we encourage these kinds of standardized measures. We need to make evidence-based self-management available very broadly, not just in tertiary care academic medical centers, which is unfortunately the case in many situations. And find reasonable ways to reimburse providers and peer educators for self-management. That's probably going to be the toughest nut to crack, but I think if we collect performance evaluation, show that we can improve outcomes, and provide people very detailed implementation plans, then I think the next step, it's much easier to find ways to get payers to actually pay. So what I'm going to do now is shift gears a little bit, and I'm going to call my posse up here. If we have 5 of us, I'm going to have them bring their, grab a couple of chairs. What I'm going to do is have them introduce themselves briefly, say who they are and their role on these epilepsy self-management projects. And then I think we'll just take some questions from the audience and hopefully have a good group discussion. Okay. Okay. Why don't we start?
Oh, okay. Well, my name is Delilah, and I do have epilepsy, and I was part of Time and SMART study.
My name's Eleanor Ryan. I'm one of the nurse educators with the project, and I started with Time. Delilah was in my group, and now she's a peer educator. And so I've been through all the rest of them. I've been working with the Epilepsy Association.
I am Carrie Clone-Zimmerman. I'm the research assistant on Dr. Sajatovic's studies for this epilepsy programs.
Hi, I'm Nicole Richter. I'm the Director of Community Programming at Epilepsy Association in Cleveland.
All right. Any comments or questions about anything you heard so far?
Yes.
Somebody said yes, I thought.
Yes.
Yeah.
I'm Nikita Worley-Bell, and I'm here with CASE, and the name of my program here is Creating Greater Destinies. And I'm trying to learn to be a community health worker, so that's why I got involved with the program here at CASE. The suggestion that I have is to have an incentive program for other men who are interested, show other men that they can relate to, and your posters and marketing and items like that. So epilepsy runs in the family, is that true?
It can. Some types of epilepsies do. Other epilepsy can be caused by a variety of things. So genetics can cause it. Certain congenital conditions can cause it. Birth defects can cause it. The other thing that unfortunately is common is head injury. So people are getting a car accident, they fall and sustain sometimes even what looks like relatively minor head injury. They can be left with seizures. The other thing is that there's a peak of onset of epilepsy as people get older. So elderly people who may be related to little strokes or something like that can have epilepsy.
My other question is, are you all participating with the epilepsy marathons to gain more men and other minorities?
So there, I think from what I could tell, you had sort of two questions, and maybe let's have Nicole answer the question about epilepsy community events that the Epilepsy Association has been involved in, and then I'm going to ask Delilah to talk a couple minutes later about engaging both men and women, including maybe you want to say something about peer educators, that we have both men and women, and some of the ideas that you all have had about reaching out to get some more men in our participants. So Nicole, do you want to say something about the Epilepsy Association and the community programs that are available?
So we, our association hosts a number of community events throughout the year. So we have a seminar series that's open to the general public, and then these feature physician speakers, and we try to pick engaging topics that are new and relevant in epilepsy. So this is a great way to engage folks who maybe haven't been to our agency before or are looking for some type of education or some type of service that we haven't offered before. And then we have a number of community events too. So we have like our race coming up in September. So we have a 10K, 5K, 1 mile walk to support the epilepsy community. So our goal there is just to kind of raise epilepsy awareness in the community, provide some education, and then raise funds that go back directly into our programming. So again, these types of events like this one and our winter walk in January are great ways for people to get involved with our agency. And we certainly promote this program at all of our agency events that we have going on. And we also do have a support group as well.
So if a person wanted to find out more about epilepsy, your organization would be a good one,
Absolutely.
Probably. Okay. So, Delilah, do you want to say something about do we, peer educators and how we...
One thing that we are doing and have done in the study is we do have a lot of male participants, more than normal, I guess. But we all know that men don't even want to go to the doctor, okay? So let alone be part of any group that has to do with health. They are not going to share much. But the good thing is we have some male peer educators as well. And they're kind of very, very open, and they discuss whatever needs to be discussed to make the males that we have in the groups a lot more comfortable. I think that you're right that we should do some different types of incentives, and we actually did kind of talk about that as the peer educators. We talked about what we can do, and we're not quite sure yet, but it's actually in the works on getting more male participants. And another great thing that we do is a lot of word of mouth. So one of the participants actually brought his mom, and he shared it with his family, and it's like, oh wow, so this is what we have going on, and I think that that's a great thing.
And if I might add also, we did, and thank you so much for that comment, because it's so important to us to be able to reach out. We had one of our cohorts that was basically from the VA.
Yes, that's an excellent point. Yes.
That one actually got us mostly men in a group. And you could see and feel that there was a different undernote, an atmosphere to that, and it's one that she addressed, the inability to be able to share something like this for decades. And most of them actually were traumatic brain injuries and so forth. So that became our own little, how do we do this again, and how do we do this better to reach out to men?
So before we go, and I'll get your question next, but that's really an excellent point, Carrie. So what we did with SMART, and this was with support from CDC because they were interested in reaching out to veterans groups. I mentioned that having a head injury is a high, that's something that's often associated with seizures. So think about, people who have been in combat, soldiers, boot camp, all that stuff, really bad for your brain, right? So a lot of veterans, there's much higher rates of epilepsy in veterans than in the general population. We actually took the time and trouble, and I'm going to capitalize both T on time and T on trouble, but we went through the IRB process to get our study approved by the VA IRB. That took us about 1.5 years. No lie. Really did. And then we had a nurse educator who was embedded in the VA, and we had a veteran who was a peer educator, okay? And we ran the group there at the VA. So we had mostly men. You're absolutely right, it was a different flavor to our group. And as a matter of fact, but there was so much interest that I am working with one of the VA neuroscientists there to see if we can actually get some VA funding to roll this out in the VA, because I think there's a tremendous opportunity. Let's get that question back there.
Yes, it's actually a comment, not a question, about how to try to get men interested and keep them for as long as you want. If there is any way whatsoever to show sexual benefits, improving of sexual outcomes, you will get them and they will stay around.
So that's a good point, and I would say if you think about all of these complications, right? Emergency room visits, falls, and that's not good for any health, leave alone sexual health, right? But definitely it's a point where having candid discussions is important. Yes.
Another thought might be, I am a coach within Motion. I'm not sure if you're familiar with them. They were Parkinson's.
Mm-hmm.
That very active in involving care partners. So that if you get the care partners more involved, what we're seeing on our end, and I work on the mindfulness end, is that if you bring in the loved ones who are just as distressed and to help with their stress levels as well, they tend to bring in the person with the condition. So you get a two for special, if you will. Bringing down stress levels of the care partners, helping them in situations as well as the person who has the condition.
One thing that we did do, we did it in the C time, I believe, is we opened it up to the families, but the most important thing is it's a self-management thing. So we're not like a counseling group or anything like that. It's a self-management. So we want the people with the actual conditions to come in because it shows them how to better take care of themselves. But what it does for the family is it helps the family to understand what's going on and what's happening. So we kind of did open it up, but we kind of asked the family to sit back and let that person take control of at least that moment in their lives.
Eleanor, would you want to say a couple words, because you've had a little interaction with family members coming in and in the group, sort of how you kind of handle that?
Well, I know when we had the seat time at the Epilepsy Association, we talked about the fact that we would invite family members because they were often the one transporting the person with epilepsy to the group. And we talked about how we would handle them being there. And sometimes, especially when it's a younger person and a parent, the parent maybe has always taken charge. And we wanted the person with epilepsy to be taking charge of their own healthcare management. So what we finally decided to do was we asked the family members to kind of sit along the back of the room, and we had a table with everybody sitting around it. We were a little nervous at first that might be awkward and that the family member would try to take charge of the conversation, but we found that everybody was very respectful. There was one parent in particular who came to almost every meeting, and she chimed in a few times, but let her son take the forefront of the discussion. So it worked pretty well. We were happy about that.
And this was somebody, it sounds like, based on what you all have told me, where the parent was really used to running the show.
Yes.
And she had to kind of disconnect a little bit.
Right. And she did.
And she did.
Yeah.
And we would open the floor up at the end for any concerns that the parents, that the family members or the caregivers would have. And interesting, because we did a Parkinson's study before, and we had a lot of caregivers in that study. And in the seizure study, I didn't find as many caregivers, even though it was open to them. So that was kind of interesting. Thank you.
Other comments or questions? Yeah.
What kind of data do you have on what patients actually do?
What do patients actually
So
do?
they self-manage, but what do they actually
Yeah.
do?
Yeah.
Oh, wow.
Will.
So I'm going to ask you. Delilah, why don't you first give it from the peer educator perspective, what people with epilepsy do, and then we'll turn to Eleanor and she'll offer you her 2 cents.
Okay, so first I have to start when I was actually in the program. They did a lot of talking about caring, just first of all, caring about yourself. You know, getting to know basically who you are, being comfortable with the fact that you actually have epilepsy. So I am not epileptic or any of these other terms that people use. I have epilepsy. It does not, you know. And so after we talked about that for a little while, we kind of talked about managing it and the funny stuff that people would say, the fun. It was like really funny to hear all of the different stereotypes and stigmas that people had. Like we had people that would think I was contagious, like I can touch you, now you have it. No, it's not the flu. I can't just give it to you. It's not airborne. We talked about food. We talked about sleep. A lot of people, sleep was kind of disturbed. I know my sleep was disturbed for years. My eating habits were always pretty okay, but it talked a lot about your sleep hygiene, your eating hygiene, being physical, getting out and doing everyday things. So, example, when I first came to the program, I was in the house all the time, didn't want to do it, didn't want to hear it. Please don't talk to me, don't touch me, don't look at me, you're in my space, I'm depressed. I'm sad, I'm fat because I'm on all this medicine, I can't get out and do anything. That's what I thought. When I came through the program, I had a lot more confidence built up because I seen that there were other people that were just like me. And I'm like, okay, wait a minute, so I guess this really isn't that bad just coming back out into society. We did a lot of homework. We did a lot of homework, and it was fun homework. You know, just self-management, learning how to talk to your doctor, learning how to talk to people around you. Me and Miss Eleanor, when I became a peer educator, we would role play different scenarios, and it would show you that no matter what's going on in life, there's a way that you can communicate. And there's a healthy way to communicate. And for the person with epilepsy or any other disorder and any other depression or anything, if we communicate better, if we learn how to communicate, first of all, not only are we helping ourselves, we're helping the people that surround us because they don't always understand what's going on with us. So we have to be able to advocate for ourselves. So they taught us those things. We did a lot. We did, like, really, really did a lot. We learned how to take our medicine. We learned different techniques to remember to do different things. Like this one young lady, she never remembered to take her medicine. She put it on top of her fish tank. When she fed the fish, she knew she had to feed the fish every morning. She fed the fish, she took her medicine. Wow, mind blown. Who would have thought to do that? But
happy fish too.
Happy fish too. But those were some things that we learned. Those were some things that we did.
Yeah, I think in the time study, there were 12 weeks, and we covered lots of wellness types of things. So we talked about diet, exercise, and then we had, various techniques, like she said, for people to remember how to take their medication, how to communicate effectively with their physician or with other people when you're having problems, how to work through a problem-solving situation. And, we weren't telling people this is exactly what you must do. We were throwing out to them information that they could then adapt to their own life. And so that was the beauty. We called the one other peer educator who isn't here today, calls it, I'm the book smarts and the peer educator's the street smarts. So I'm the one kind of running things, going over the information, that's on the slides or in their book. And then the peer educator chimes in with their example of this is what I've done. And that's where the power really comes. Because then people know that they can take this information and adapt it to their own situation. And there's countless little stories and examples of that. Simple things like the other peer educator uses his phone a lot. So when he tells a story about he has both mental illness and epilepsy, and he had a really hard time accepting that he had both of those as a young man. And he ended up being in the hospital for a while for his psychiatric condition and got his medications more on track with his epilepsy. And he came out of that experience realizing, wow, I am better off when I take my medication. Maybe it's okay for me to admit that I have epilepsy. And then I think he got involved with the boards, coming up with the IRB plan and all that. So he talks about the fact that he had to go through all that in order to come to grips with it. And so he talks a lot about, I am not epilepsy, I have epilepsy. It's something like my personality, but I just carry it around with me. So that really strikes a chord with the people in the group, because it was always amazing in that first group session for each cohort how amazed they all were to be with other people like them. Because of the stigma, some of them had never really talked with anybody about the fact that they have epilepsy or mental illness. And to see them just kind of relax was always amazing to me. And be able to talk about that. Does that answer your question?
Well, I was interested in the fact that somehow they're good sleep hygiene, correcting their sleep. The sleep-deprived EEG is used to elicit abnormal EEGs and seizures. So I think that's a target, an important, probably the most vital target.
Right. And for some people, sleep is a problem, others not so much. So we're pretty much presenting them the information they need to then work on it themselves. So, they might have questions, very specific questions about their medications or whatever. We're turning that back to them and saying, that's a really good question to bring up with your doctor. And we encourage them to keep a list or a little notebook or something where they can list things they want to ask about when they go to their next visit. And that's a real important skill to have, because as we all know, doctors have very little time when they see the patient. And that they need to be ready to kind of prioritize their list and say what's most important to them, and then find ways of getting those questions answered.
So you had a comment or question?
Yeah, I have a question. So I know that your main studies, and it sounds like across the group, have been focused on depression and improving depression symptoms. But it sounds like, based on what Delilah was talking about, that going through the program there was major life change. So I was curious about what are some of the other things that you've measured, and then through the groups and through the participants, have other things bubbled up that would be indicators that would be important to evaluate and assess?
So let me say something about the data, and then I think what I'd like to do is maybe bring it to Delilah, and then maybe Eleanor and Carrie, if you might want to share some, based on experiences of other things that people have noted have been real improvements. But the really, really, really cool thing, in my opinion, and as sort of a pragmatic person, it all comes down to money at the end of the day. Not for us as human beings interacting with each other, but when we talk about the government and insurance companies and stuff like that, they don't really care about our personal well-being. I mean, they do, theoretically, but at the end of the day, economic decisions often are made on economics, right? What we were able to show in our SMART study, our primary outcome was actually counts of negative health events, NHEs, right? I was showing you people have a lot of seizures before they start our program. We are able to show that if you're in SMART compared to treatment as usual, we have a significantly improved reduction in negative health events. Okay, so that's like a hard stop, right? We reduce epilepsy-related complication, which, if you have, whether you have health insurance or not, is costly. Because if you go to the emergency room, not only is that really bad for you and it's a terrible place to hang out, it's expensive, right? So that, I was extremely thrilled about that, to be able to say, yes, we have hard data to show. You know, depression is cool, but, you know, payers, man, they're not as concerned about that. But NHEs, that's where they have to step up to the plate and shell out big bucks. So we very good outcome. We were able to show that epilepsy self-management, using a standardized measure, that people have improvements in epilepsy self-management. We were able to show improvements in stigma. Okay? So other important standardized outcomes are clearly improved. Quality of life. We use a quality of life measure that has multiple subscales, and we show that people have improvements in their ability to manage kind of lifestyle changes, sort of activity levels, diet, nutrition, manage their medications and their safety much better, looking at all of these dimensions. So we're still analyzing the full set of data from our randomized controlled trial, but we do have a manuscript that is winding its way through the reviewers. The reviewers have been pleased with our data, and actually we just submitted a third revision last week, so hopefully we'll get an acceptance soon. But let's put a human face on NHE's median counts, and let's. So Delilah, do you want to say something about what's better?
I've had epilepsy for 18 years now, so let's start with that. My life was like really crazy. Depression, schizophrenia, all types of stuff is going on. A lot of it may be caused by some of the medicines and everything. I'm not really sure. But I know when I started the program, like I said, I was tired. I was in the house. I didn't want to do anything. I wasn't going anywhere. Don't ask me nothing. Don't touch me. Don't look at me. Anything. Started in the program. I was still kind of laid back. So I'm going to fast forward it to right now, today.
How long has it been?
2013, I think, was time.
Yep.
So it'd be like 5 years. Yeah.
5 years. So when I started the program 5 years ago, I wasn't doing anything. Now I'm in school. I am more active in the community. My depression levels have lessened tremendously because now I'm not scared. Now I know that there are other people that are just like me. I have I don't even have a toolbox anymore, okay? I have a whole chest about this big full of tools and things that I can use and pull out. If anything happens, if I need to know anything, if I need to remember anything. They gave us books, and I still use my books, and I still lay my books out, okay? So people are like, oh, okay, well, maybe this is what's going on. But I have a whole cabinet full of things that I pulled and used from the toolbox. I'm not working full-time yet. I still do a lot with them, but I was able to find me another small job because I can't work too many hours because I still have too many health complications. But I was able to actually get a job to get me out of the house that also decreased the depression part. So my life is great now, considering. I don't have as many hospital visits anymore. But not only have I learned how to deal with my depression, I have learned how to help my children. They don't have like depression or anything, I don't believe, but I've been able to help them with different management skills. You know, we did some breathing techniques and some other techniques. So not only has it helped me personally, I can say, okay, well, you can't sleep. Well, maybe we can do these things. Oh, you're feeling this kind of way. Maybe we need to change that. My whole lifestyle, everything about my life has changed since I started here. And I was, as they say, I was a hot mess. But now I can be more encouraging to help other people, because I was always a happy, bubbly person. But that depression and seizures and stuff like that, I'm like, I'm not going out there because I'm going to go out there. I'm going to be by myself. This is going to happen. And then what? So I'm better off in the house. And now I'm gone everywhere. So that's my take on that.
Yeah, the first session with Delilah in the group, you know, everyone has to introduce themselves and say who they are. And she was sitting like this, leaning way back from the table. I'm Delilah. I don't like people, or something like that. And, you know, I'm thinking, oh boy, this is going to be difficult. But she opened up and really participated and, you know, shared a lot and
Went on to help many others.
has come on to be an excellent peer educator. And really, I just sit back and make sure we, you know, end on time and cover all the stuff that we have to cover, because it's a research study. We have to follow the script and the book and everything. It's the peer educators who really do most of the work, and you can just see the other participants really paying attention to them and looking to them as an example. And again, like Martha said, it's not that they're perfect. They're not perfect, but they have shown that you can, you know, manage your life with this chronic condition that is so unpredictable and still have a good sense of humor. That's the other thing that I've noticed. The people who tend to do pretty well can laugh about it. And we've had some pretty good laughs. I mean, you guys have told some pretty good stories. And people laugh, and it's amazing to me. It's very inspiring to me to see how people can maintain their sense of humor.
And I think Nicole can share with us. We just had a presentation of the same program at the Epilepsy Association, where one of the participants in the community time, he had a lot of difficulties joining the program.
Yes, there was a lot of barriers, and we kind of had to drag him along, and he's part of our case management program, so we've known him for quite a while. I don't know how he's going to do with this. And then just to see the look on his face when you know, Eleanor's talking, and they're like, okay, and then Delilah says something, and they all just like lock in on her, and you can just see the light bulb go off, and then he says, oh my goodness, no one has ever, I think we were talking about some sort of negative interactions between drinking, alcohol use, I think, and mental health and epilepsy. Wow, no one's ever told me that. And I know for a fact that his case manager has told him that many times. But it just doesn't connect the same way as when you're hearing it from somebody, you know, who's maybe been there and, you know, has experienced these things before, and just to see like the change, and that just really sticks with people.
And so we go to the Epilepsy Association, do this presentation, and I see this person, and I go to introduce myself, and it's him, and I did not recognize him.
Not at all.
At all.
Because he looked so much more pulled together. Yeah.
He decided that this was it. He's going to break this cycle. He's in recovery resources now, managing, cut his hair, got glasses, cleaned up, and we did not even recognize him. But this is actually not unusual for this program, that people actually turn themselves around like that.
And it's when he was ready, because it's interesting. Because when we make, part of the program is after we're done with all the sessions, depending on the particular iteration of the study, we both make follow-up phone calls, or maybe I just do. And when I was making follow-up phone calls with him, you know, I was mentioning that he, you know, why don't you go to, you know, this recovery resources or here or there. Well, you know, his ride was late, or there were all these excuses, and I thought, well, okay, I'm just trying to encourage him and give him some suggestions and, you know, let him handle it. So I kind of thought, well, who knows what's going to happen? And then to have him show up and have decided on his own that it's really going to happen. Something stuck somewhere.
So the effects can be profound. I do want to say, as we're kind of getting through our time here, is that we are rolling out a community-based version of SMART. And as Carrie mentioned, we had a community event last week at the Epilepsy Association. Very nice turnout. We had a lot of our previous, I shouldn't say a lot, but a number of our previous graduates come to the program and speak very well. What was particularly exciting for me is we had a contingent come up from the Epilepsy Association in Cincinnati, Ohio. And they were very excited to hear about our program. I think they were particularly moved to hear Delilah's and our other peer educators and former graduates kind of testimonials to say this has really helped me. Not, the idea of teaching a man to fish versus giving a man a fish. I mean, teaching somebody to be able to manage their health is the most profound good you can do. But they wanted to help us deliver the benefits of this program to their constituents, to their members within their community in Cincinnati. So what we're working on right now, and this is Carrie is like the recruiter with the mostest. So she's goes all over town, knows just about everybody. Yes.
So it looks like there's flat. I mean, he asked me that if you want to distribute them to your networks, maybe that would be.
So the Cincinnati group is searching their membership and trying to get referrals from us. Like, how are we going to do this? We're going to figure it out. We'll figure it out. We usually have one in person, but we may do some using Zoom or something where we can connect remotely. And then the rest of the sessions are done remotely anyway in the time program. But we would love to have those of you who know people with epilepsy, if you're out in the community and you're someplace and you want to, it comes up, we would love to have referrals.
And those flyers can go on any bulletin board. All of them.
So let me just give just to make sure that we don't get in trouble.
Oh,
so if you're in private property, you should ask and don't go to a federal building and put this up with me.
Right.
Don't ask me how I know that.
That'd be our secret.
But if it's an entity, you want to make sure you have permission to put up flyers. Any last minute comments or questions? Our panel, any last words?
Thank you so much for supporting this project. It's been really interesting being the assistant on this project and just seeing this going from, our first peer educator, our first advisory board. I recruited him in the homeless shelter in the cafeteria that they had cleared out just for us. And it was a long time ago, and we've journeyed this far. The peer educators are actually our best, have the best outcomes, obviously, but they've come so far because all of them were participants in the program. So from homelessness to, having his own blog online and doing other management courses in other agencies, to another peer educator that we recruited a year or so out of jail, to now actually looking into master's programs in social work because this is what he wants to do. From our veteran who could not figure out the seizures at all to now being part of what they call it, like the ombudsman or the people, the people who help at the VA. And
so like a patient navigator to help people navigate with the VA, which is a huge bureaucracy. How do you advocate for yourself?
To all of those things. And those are just anecdotal, but they are representative of what this program has done for others. And so I appreciate the support.
Well, why don't we conclude then, and we'll be around here for a couple minutes if anybody has any questions or comments. Thank you again for giving us your time, your interest, and once again, your excellent comments and questions.